Good morning. Good morning. I am just going to give us 30 seconds to get settled, and then we will jump right into the culturally inclusive care panel discussion. Okay. All right, so let's jump right in. Good morning, and welcome to the culturally inclusive care panel discussion, where experts will give perspective and advice on providing care that embraces and integrates a patient's cultural beliefs, values, and practices. My name is Natalynn Dunson. My pronouns are she, her, hers. And for anyone without a camera or who may have a visual impairment, I am a Black woman of lighter brown complexion with reddish hair. And today I'm wearing a red sweater. I am the Director of Diversity, Equity, and Inclusion for the RWJ Barnabas Health Medical Group. Over the course of my career, I've been a licensed attorney for more than 25 years, a judge and adjunct professor. I hold designations as a certified diversity professional, a certified compliance and ethics professional, as well as an EEO professional's certification. As you may know, RWJ Barnabas Health is the largest, most comprehensive academic healthcare system in New Jersey. RWJ Barnabas, we have a team of directors of diversity, equity, and inclusion across our healthcare system who deploy defined, mission driven, diverse, and equitable strategies and goals to both facilitate and to sustain a respectful, inclusive culture for employees, as well as to optimize delivery of high quality, equitable, culturally competent, and patient centered care in the communities in which we serve. Through the collaborative efforts of our team of diversity, equity, and inclusion directors, our corporate office of diversity, equity, inclusion, and stakeholders across our system, we have established a roadmap for diversity and inclusion success. I'm very proud to share that for 2 years now in a row, we are among the top 1,000 organizations that Newsweek Online has listed as one of America's greatest workplaces for diversity. I'm also very proud to share that the Human Rights Campaign Foundation has designated our hospital facilities as LGBTQ Healthcare Equality Index leaders for inclusive and affirming LGBTQ plus patient care. Joining me today are three esteemed panelists. I'm going to share just a short portion of their professional experiences and honors, but I encourage you to go into the designated area and read their full bios. So we have Dr. Jacqueline Jones. Dr. Jones is an associate professor of otolaryngology at Weill Cornell Medicine and has practiced medicine for over 35 years. She has a busy clinical practice in New York City and participates in clinical research and resident education. Dr. Jones has been voted one of the top 100 Black doctors in America and has been elected to Castle Connolly Top Doctors in America for over 20 years. She's held leadership positions at the NIH as well as on local and national organizations. Dr. Jones is the founder of Vaccinate for Love, which is a nonprofit formed during the pandemic to provide physician led information sessions for community organizations and businesses around the world on the importance of COVID-19 vaccination. We welcome Dr. Jones. Next, we have Dr. Anais Ovalle. Dr. Ovalle is an infectious disease physician and director of the population health track for the Kent Hospital Internal Medicine Residency Program. In her curriculum, she emphasizes the need for effective healthcare delivery that meets the social, cultural, and linguistic needs of patients. She's an assistant professor of medicine at the Warren Alpert School of Medicine at Brown University. She's currently serving on the Grants for Emerging Researchers Clinician Mentorship, also known as GERM or GERM, and the Inclusion, Diversity, Access, and Equity Committee. Then we have Dr. Chyke Doubeni. Dr. Doubeni is a professor of family medicine and an academic healthcare leader with a current role of Chief Health Equity Officer and lead for diversity, equity, and inclusion for the Ohio State University Wexner Medical Center. He's a clinical epidemiologist. He's led major studies showing harmful variations in the quality of cancer screening, lack of appropriate follow-up care for abnormal screening tests, and health system and societal barriers that lead to inequitable care. He's chaired the USPTF Race and Racism Work Group to transform the recommendation development process through a health equity framework. We welcome all three of our esteemed guests. Now, my challenge and goals for our panel today are to call out some of the critical challenges, share their perspectives as to the work of physicians and providers when it comes to the care of diverse populations, as well as when it comes to both culturally sensitive and culturally competent care. And we'll close out with some key takeaways, some of their golden nuggets, and answer any questions, time permitting. So I just encourage everyone, if you have that aha moment or something really strongly resonates with you, you might want to jot it down because I believe it will be worth it. And so without further ado, let's move right into the questions. Let's start off with some perspectives, and I hope that each of you will share. The first question is, number one, and it's two-part, how do you define culture? And how do you recognize and appreciate the cultural diversity among patients in a healthcare environment? And Dr. Doubeni, if you don't mind, I'd like to start off with you.
Well, thank you so much, Natalynn, and I really appreciate the opportunity and honor to be on this panel. So maybe I should start off by saying that I'm sure listeners will recognize that I have an accent. I'm a Nigerian, and I come from Nigeria and immigrated to this country. And this is also important for culture because within Nigeria, we have myriads of cultures and languages in ways that is important for us to understand, for us to be able to work with different population groups. So to me, culture represents the norms and values, preferences, as well as the expectations within a particular group of people. And in that group, it can be as small as a small village. It can be as large as a country at times. Sometimes a culture is defined or formed by language or shared language within that area, a shared dialect. Because in my own community back home, we have multiple hundreds of languages, but also dialects within those languages that really define different cultures. So I see this as an opportunity for us to, one, learn about a person in front of us when we're providing care or any social interactions. And I really like the words of Margaret Mead, and I'm afraid I won't be able to paraphrase it well. But basically it says for you to understand someone and understand their values, you really have to really go back and understand how they were brought up, the environment in which they were raised and nurtured. And that's basically what culture is about. So it's how you were nurtured and raised. And no culture is better than the other because all of us bring value to the lives that we live. And the diversity of cultures is what really makes us unique, creatures in the world.
Absolutely. Dr. Jones?
This is such a great question to start with because I think, especially for doctors who are starting out, who are residents, fellows, and starting out in your career, it's really hard to juggle all the things that you have to do. We all know that medicine is becoming so compressed. I see 40 patients in a day, and I have 15 minutes with each one of those patients, and I have to walk into that room. I have to get the information. I have to make a diagnosis. I have to examine them, and I have to make a treatment plan in 15 minutes and get them out of my room. So to be aware of your surroundings is so important. By walking into that room when you're interacting with the patient and looking at them. And many of us are on Epic medical systems and all these medical systems that cause us to sit down and look at a computer and not turn around and look at the patients. And, you know, having started medicine 35 years ago, you know, we charted, and you could sit there and look at the patients. So one of the things that I think is really important is to look at who you're interacting with and recognizing them and recognizing where they may be coming from and why they are in your room to see you. And one of the things that I start out with, and again, you've only got a limited amount of time, so you have to structure that interview. But one of the things I'll say is, tell me a little bit about yourself and your family. And that might be, where do you come from? You know, tell me a little bit about yourself. Now, I may limit that discussion to a minute or two, but it helps me to understand how they culturally define themselves.
Wonderful. And let's round it out with Dr. Ovalle.
Hi, thank you for having me here. I actually think that culture really shapes the individual and actually helps provide a framework as to what, you know, how you're going to be working with them and how they perceive the world and how you are going to be, you know, kind of adding to that. And so it's the basis of how you build trust in with the medical system and just overall with a being. So if you're thinking about culture in general, just the way that we approach it, it's basically, I think it was previously mentioned, a set of beliefs, behaviors, customs, traditions, practices that are shared by a group, shared by the individual. It could be just even art, like music, cuisine. So kind of having a space for the person to invite you into their lives and invite you into their culture, I think is the basis of what is honestly the art of medicine and what is building trust.
Wonderful. And I think that leads into this next question, which I believe that Dr. Jones, you kind of really led us into this question already. The question was, and so I'm going to ask I'm going to lead with Dr. Ovalle and then go to Dr. Doubeni, because I think that Dr. Jones, you've already done a thorough job with this question. And the question is, can you provide examples of how you deploy cultural awareness and adapt your communication style to meet the cultural needs of diverse patients? So why don't you take that first, Dr. Ovalle?
So for me, I go in every encounter like a blank slate. So I'm in a space where again, I wait for the invitation from the individual. I ask kind of what their background is and what overall, like if I'm seeing them for a particular purpose, like say if I'm seeing them for, I practice both in the internal medicine and the infectious disease space. So if I ask them about diabetes, I ask them, okay, you know, what are your beliefs about diabetes? Kind of what is the structure in your life about this? Like where, you know, what does your surrounding like day-to-day habits have to do with your diabetes? I kind of have them come from the patient themselves as opposed to me imposing it on them. I just ask them, you know, what are your, you know, what kind of foods do you like to eat? I try to focus that conversation on what their day-to-day dietary habits are, not necessarily, you know, making a face. I try keeping a very blank, just absorbing what their life is, and then kind of seeing what dimension they're practicing to try to transform that into something that would be helpful to them. So it's really you check yourself first always, because you can't practice cultural competency at all if you don't understand and are aware of your own biases that you may have. So I think that's where I start from. I check myself at the door, and I allow myself to just absorb what the person in front of me is giving me. And then, you know, from there I sit and I explore their behaviors, their knowledge, their attitudes, and just overall their practices.
Very interesting. Dr. Doubeni? Well, I'll pick up on you with the next question.
I'm on mute. I'm sorry.
Oh, there you are. Okay. We want to hear from
Oh,
you.
sorry about that. I was on mute, and I was
That's
basically said
okay.
that was really powerful. Uh,
Yes.
and a couple of things come to mind, which is that, observe but don't make assumptions, right? When you're trying to engage in culture. And I agree completely. Check your ego and your own culture, not at the door, but at least be aware of them. Because the culture forms who we are, and we shouldn't deny that. But I do think the humility that's required for us to be able to understand the person in front of you and actually be able to provide care that is appropriate and aligned with your cultural values is really important. I think ultimately there's this shared concept we have, or the concept of shared decision making, which is that the patient ultimately has the right to decide what is done to him, her, or them. And I think that could be a framework to start. But I do think it's really important, and that's what I do, is to ask. And sometimes I have the luxury of time, Dr. Jones, to actually spend time with patients and say, tell me about yourself. Where have you been? So where did you grow up? Where have you traveled to? What kind of foods do you eat? As a matter of fact, one of my questions that I ask patients all the time is about diet and physical activity. And it's amazing what you discover from that. Tell me about your family, right? But I think way beyond that, what is also important is that as we look at the patient's culture, don't make assumptions that because of a cultural belief or norm or other values they hold, that they don't want a particular type of treatment. Everyone desires the best life possible. So I think that's really important to keep in mind. But I do, that's a very powerful, Dr. Vi.
Very interesting. And that kind of leads us, as we're talking about that becoming more aware, checking our own biases, self-awareness as well as awareness of them and their, not just their medical issues, but the environment in which they come from.
Mhm.
And that's going to lead us into, I'm going to touch on something, cultural taboos. And so with respect to providing culturally competent care, what comes to mind when you hear that term, cultural taboos, and how should healthcare professionals address the needs of diverse patients and families when it comes to navigating cultural taboos? And since you're right on my screen, I'd like to go in this order. Let's start back off with you, Dr. Doubeni, then we'll go to Dr. Ovalle, and then we'll have Dr. Jones bring that home.
I think I set myself up for this one
Yes,
by
you
leaning
did.
forward. So this is a very important question about cultural taboos. What do some cultures consider as things that they do not accept or would take offense at? And I think readily of some cultures that maybe a man examining a female is not acceptable, or seeing a female naked or undressed is not acceptable. And so those are areas that would be considered taboos. But it is, to me, as opposed to framing this as a taboo, is
Mm-hmm.
what are some cultural preferences that we
Mm,
need to recognize and be aware of and address? Because at the end of the day, if a patient needs critical care and you are the only person there, that taboo shouldn't stop you from doing it. As a matter of fact, time and time again, the rabbis and the imams have ruled that, in my awareness, have made those allowances to allow for critical care to be provided. But I think those are some examples that, even in my place of work, I'm the chief diversity officer. I make the same mistakes. You know, offer my hand to make a handshake, and someone sort of hold back and said, "Oh, God, so I just made that mistake. I'm so sorry to do that," and I get this beautiful smile back. And I think it's what we need to be aware, that the person in front of you needs to be understood so we can interact with them in a way that's most respectful. And by the
mm.
way, this is also an important concept in the culturally and linguistically appropriate services standards that HSS requires us to, or expects us to use in providing care to everyone who seeks care with us.
Great. Dr. Ovalle?
I think that many points were made there that were really salient. From an example standpoint, I think of one of my first patient encounters where I had a patient who was iron deficient, and I naively came in, saying, "Oh well, we have to increase your iron in your diet." Did not ask what kind of diet they had, and so they were vegetarian because they were Hindu, and I sat and I said, "Well, this was I felt as if my foot was in my mouth, but I acknowledged what was said and done, and I said, I'm sorry. I'm sorry I assumed." And that was one of the biggest teaching moments where I stopped assuming and I began asking. And so, I think dietary preferences and making sure that you're in line with their dietary preferences, that necessarily, again, I don't think that they should be named taboos. I think it's definitely a culture.
Are we frozen or am I frozen?
We have a brief technical malfunction.
Yeah.
A brief technical difficulty.
Ovalle might be frozen.
Okay.
Yeah.
All right. If you
Land.
can hear us,
Oh, hi.
there we go.
Sorry.
There you go. Go
Okay.
on.
So I was discussing how with Jehovah's Witnesses, you can create plans that avoid blood transfusion beforehand. And so delineating that in clinic, you can have something set. So then if something were to happen, you can have at least a set plan of or at least an approach. Other things I think of that I've encountered would be end of life care and just giving people space to have what they want to do in terms of religious ceremonies, and even being a part of them sometimes, going to them and showing your one acceptance and also your support. So those are just a couple of things.
Wonderful. All right, Dr. Jones.
So I think when we were talking about these questions a little bit before, I sort of voiced my opinion about the term cultural taboo, because I think, as Dr. Doubeni and both Dr. Ovalle said, our primary goal as physicians is to provide the best possible care that we have. And our responsibility, no matter what happens, is to provide that best possible care, but in a culturally sensitive fashion. So I think when you're first starting out, I've been in practice for a really long time, and I work in a very diverse city, New York City. So I come in contact with a lot of people. And one of the things that I learned early on was to talk to patients about the things I didn't know, to walk into the room and say, for us to have a really effective care, we need to be partners. And you need to help me to learn how to be an effective partner. Tell me about the things that I can do to help be a good physician to you. And I have I have an office in Brooklyn. I have a big Hasidic population. So, just as Dr. Doubeni come in, you can't walk in and say, hi, put your hand out. So no, I don't shake, well, after COVID, we don't shake hands with anyone. But before that, I didn't shake hands with any, I stopped doing that. But on the other hand, if I have a father who comes in, I do a lot of pediatrics. If I have a father comes in with their child and they have their child sitting on the child's lap and I need to examine the child, I'll say, listen, I need to examine your child. I might have to touch, our hands might come in contact. And they say, okay. So, but I've recognized, I've acknowledged, but bottom line, I have to examine that child and I have to do what I have to do to give the best possible care.
Natalynn, if you give me a moment, and
yes, please.
So a lot of what I do also is research, and reflecting on this conversation, what I want to also sort of share is it's amazing how much we've learned from culture to be able to inform innovations in care. And the point made about Jehovah's Witnesses and blood transfusion, right? And if we didn't have to wrestle with that reality, some of the innovations we have about how to replace iron, it may not have been readily thought of. So I think beyond thinking about culture in the context of providing direct care, it really goes back to the fact that diversity in our community forces us to create innovations that in the end benefits everyone.
great point. That's a great point. I was just going to bring up how you all touched on really the human experience, and also the fact that we are all works in progress, right? None of us are perfect. We're all works in progress, and giving grace around that. And I also wanted to just re-emphasize what you talked about in terms of cultural preferences versus cultural taboos, that perspective, and how that changes the whole perspective and how we even look at it as not being a negative, a taboo being associated, with negativity, to preference, something very positive. So I definitely appreciate all your perspectives around that. And I'm going to switch gears a little bit. In the context of treating patients, do you integrate alternative medicine or complementary medicine, or how you look at that, with traditional or Western medicine practices? Talk to us a little bit about that. I'm going to jump into Dr. Ovalle first this time.
Oh, thanks. Well, I do, but it essentially, I think of it as integrative medicine, right? Where you're combining what is our conventional Western medical treatments that we learned about, and then we think about alternative therapies, whether they be from Eastern medicine or other areas. You think about how you can make a plan that is a 360 is kind of what I think of, like, how can we make something that it complements each other to actually, have the person in front of you feel better. I recommend acupuncture all the time. Acupuncture all the time for things like chronic back pain, arthritis. My folks who are living with HIV, I recommend them to get acupuncture for any joint aches or pains, and even migraines. So I think of acupuncture as one of my go-tos. A lot of other practices that I invite people to do is mindfulness-based training, particularly for folks who have anxiety, depression. I'm just going to list off all the things. Turmeric. I tell people turmeric, if they don't want to take an anti-inflammatory, they can use it. Sometimes it works, sometimes it doesn't. And then yoga and physical therapy really go hand in hand again for those muscle aches or pains. I go to a chiropractor. It's not for everybody, but anytime folks want to not use medicine, but want to reduce pain from something like depending on where the pain is. I will say I am avoidant of saying for neck pain, but for lower back pain, I say using a combination approach of spinal alignment, and there's an aromatherapy sometimes as well, in addition to physical therapy. All of those things, I actually say, if the benefit outweighs the risks, and that's how I frame that conversation always. What is the risk of you doing this in addition to what we're recommending? And then what is the potential benefit? If the benefit outweighs the risk for the individual, because it's not me that's saying that. I can't be the person to say, there are some absolutes, yes, but then it's also like, what does the person in front of me prefer? Some people don't want to take medications. And if they don't, well, then that list of medication-based therapies gets much larger compared to what would be, okay, I'm using back pain as an example, but take Tylenol, take ibuprofen and see what happens. So I really, I use them a lot. And it's mainly because I can't be the person to sit and impose what I think is best for the person. I will tell them, okay, well, this has worked anecdotally, but anecdote is anecdote. Yeah.
Wonderful. Dr. Jones.
So I think Dr. Ovalle said something that I think is so important. We more look at this as integrative rather than alternative, because I think if we look at the way that we use supplements, we use acupuncture, we use yoga, mindfulness, it really has become part of sort of mainstream practice. And I think for me, COVID was one of the big changing points. Early on in COVID, there was so little that we could do to help people. And, I started through my nonprofit working with doctors in other parts of the world. And especially in Europe, integrative medicine is a big part of what they do. And we had some studies that we looking at, vitamin C, vitamin D, omega-3, and zinc, and how that it may affect and down-regulate the immune system in patients who are undergoing these flares of COVID. One of the big groups that I dealt with early on in COVID was young people who lost their sense of smell from COVID. And, it was interesting when we looked at that group of people, it was mostly young people who had milder cases of COVID, who had the highest loss of sense of taste and smell. And looking at ways to help them overcome these. And one of the things that we found was smell training, where you would take different scents and try and visualize that object like a rose, and then take the essential oil and smell it. And we're trying to rewire the brain, because what our research found is it wasn't that the nerve was damaged, it was that the sustentacular cell, which is a cell that supplies the nerve with food, was damaged. So we could help to regenerate those nerves, but it took some creative thinking. So I really think that COVID for me was one of the big changing points in looking at integrative medicine and how we utilize it in our everyday practices.
Thank you so much.
So as someone who grew up with traditional medicine, I always chuckle at this idea, and spot on. What is traditional medicine? What's alternative medicine? What is Western medicine? Where did Western medicine come from in the first place, right? Let's think about penicillin. Where did it come from? It came from fungi. I'm a big fan of integrative medicine, and let me tell you why. But before I get there, let me just share thoughts that's been echoed. Please, by no means, dismiss your patient's use of alternative medicines, right? And I agree with Dr. Vai. Understand the risks and benefits of what they are doing. If the risks outweigh the benefits or there are severe interactions, then there's a reason for you as a physician, a practitioner, to advise them about this interaction and what the harm it could cause. The vast majority of them, we've learned from them. Let's think about physical therapy. I wonder where it came from. I don't know, actually. Maybe someone can tell me. But if you think about it, I don't see any Western sort of chemicals in there, right? And yet it does enormous good. Imagine you had a broken leg, you had to sort of learn to rehab. So that's really important. The other piece I want to emphasize is the power of belief, right? The power of belief, right? We talk about the placebo effect. But believing you can feel well, I'm very confident can help you feel better. And someone's taking something because they believe it will help, and we dismiss it. Once insulting to their culture, because a lot of these things are culturally based or patterns, insulting to their culture, and I think it also diminishes what they are doing. But I do think acknowledging and perhaps validating, if necessary, what they are doing is important, unless there are potential for side effects. So that's also an important thing to do. So stress is, one of the biggest drivers of health. We get stressed, we don't sleep well. We don't sleep well, our immune system's affected. If we don't sleep well, all of this can lead to cancer, many chronic illnesses. We do know that lack of sleep is the carcinogen. Think about it, can lead to heart disease and all of those wonderful bad things. And so centering ourselves with these integrative approaches, mindfulness, right? Acupuncture, Ayurveda, whatever you believe in and do that helps you is important. So our role as clinicians to understand the risks and benefits of this. Many times when I confront a new thing, I don't understand. I need to educate myself to understand what it is it does, if there are any harms associated with it. So what I do want to stress is that this is important to some cultures, and unless we can find a reason why it's harmful, there's no reason why we should try to dismiss it, because most times we find out years down the road that there's a benefit, right? Prayer, for instance. If your patients are praying, please encourage them to pray, right? Thank you.
Thank you. That's so rich, so rich. We could stay right there, but I'm going to switch gears yet again because I want to give our guests as much information as you have to share. So let's go from the broad to a more focused area, mental health. How do you approach discussions about mental health considering potential cultural stigmas or differing perspectives on mental well-being. And since I still have you, Dr. Doubeni, right in my screen, I'm going to go with you first.
Oh, mental health is it's big for us right now, especially post-COVID, right? If nothing else, we have more need for it and less of the resources we need to address it effectively. And mental health untreated is one of the biggest leading causes of disability across the world, hands down. And it has no respect for age and socioeconomic status. And in many cases, it's intertwined with substance use and other things. And sometimes people use alcohol to treat mental illnesses, and we don't often diagnose it well. And that's also because mental health expressions, I would say, it's not just culturally patterned sometimes, but also male-female differences in how people express or even diagnose with mental health. Because oftentimes we attribute mental health illness in women to something else, and then it's not diagnosed and treated. So it's really important to do. Some cultures don't really understand the concept, even mine. The concept of depression. What in the world is that? You just get up and go, right? And so I think going back to some of the points raised earlier, for us to address mental health correctly, the instruments we use may need to be adapted. So let's think about PHQ-9. I think understanding what it means for someone's culture to feel sad or feel hopeless, right, may differ from one culture to another. This is where, to me, it's important for us to know our community. And I'm a fan of community engagement, understanding within that community what it means to feel depressed, feel sad, right? It's really important. So I hand it off to others.
Dr. Jones. Oh, did you hand it off to Anais Ovalle? Did you hand it off to someone? I didn't hear you. Okay, Dr. Jones. Let's go with Dr. Jones.
I really love what Dr. Doubeni was saying about how we have to maybe change the way we talk about it. We have to be culturally sensitive in the way that we talk about mental health, and we can't and this may not be, it may be gender, it may be culture, it may be so many different things that have patients not want to address their mental health issues. But as we said before, it is so important. So one of the things that I'll talk about when I talk to my patients about dealing with their mental health issues, I'll say, I know that, so I see a lot of patients with reflux, and reflux is one of those things that comes from stress. One of the big culprits in reflux is stress. So say, I'm seeing a lot of reflux, and that's why you're having these problems with your throat, you're feeling nauseous. One of the things that can affect reflux is stress. And, we live in New York. This is such a stressful environment. I've always found that getting a little support in dealing with the stresses that I'm dealing with in my life has been really helpful for me. And let me give you the name of a couple of people who I've worked with who I found have been so helpful. And some people are not open to going to a psychiatrist. And I don't always recommend a psychiatrist because, as we all know, mental health is sort of fractionated, where many psychiatrists now are giving medicine, and many therapy is done by licensed clinical social workers and sociologists. And I also work with someone who really can't come there. I work with someone who's a life coach, and she's an acupuncturist / life coach. So if I have a really high-powered Wall Street executive who's coming into my office and just doesn't want the idea of going to a therapist, I'll say, well, let's talk about maybe a life coach. And a life coach might be someone who helps you in dealing with your stress. And this is someone who I work with a lot, who understands how to help people talk about the things that are bothering them. And if they really feel that they need referral, building up that relationship that I, unfortunately, being a surgeon and a specialist, may not have the time to build up with, refer them. And the other people who are really big partners with me are primary care physicians. And I don't hesitate to pick up the phone or message one of my patient's primary care physicians and say, I'm worried. This person is really not looking great, and their stress is really affecting their health, and I don't have a personal relationship with them. So can you help me? Can you maybe reach out to them? Can you talk to them? Can we form a partnership in getting that person the care that they really need? So I think working as a team has also really worked well for me.
Wow, great. Dr. Ovalle?
I applaud Dr. Jones and being collaborative. I will say, from big picture, I agree that you have to be able to at least have somewhat of an idea as to what is how that particular person describes or what is mental illness to the person. You have to, do they even acknowledge it? Because if not, it's going to be different approaches, and you want to highlight the similarities that you're able to find there and try to understanding again that experience. But also, I try to engage in discussions about emotions and try to put words to emotions and what their struggles are. I ask about what's going on in life and just even coping mechanisms. And so that's kind of how I allude to it. And if I'm utilizing an interpreter, I will say, I want to make this point before anything. Make sure that you have language congruency. Like, use an interpreter at all, if you're able to use one at all times. And use proper interpreter, just overall, like, respect and communication, where you're speaking with the patient. The interpreter is a person, ideally culturally congruent interpreter, because if you have someone who's from Argentina and you're speaking to someone who is Dominican, there are differences in that culture, even though they speak the same, they speak Spanish. And so I think I potentially, if I'm going to have a conversation surrounding mental health, I actually ask the interpreter services to get me someone who is, because that then minimizes what could be taken out of context, especially if you're using some kind of colloquialisms, etc. And then I also try to offer resources in the community, even if it's peer support. Like, I invite people to go and to different places in the in their community that offer either bilingual services, culturally sensitive therapy options, or even just community-based support programs. There are a lot more than you think there are. I know a lot of people say that I don't know where to find them. If you go into even like the YMCA, the Y will have the basis. Like, you have to be willing to commit the time, or have someone on the team to commit the time to do the march, to find what the resources are available to you. There people have community liaisons or cultural liaisons or community health workers that actually do this, and they know the community very well. So I encourage engaging in with the community through either those liaisons, to be able to offer those resources to the individual that's in front of you, and just overall being integrated in and involved with those community leaders. So then they, if they see you, they'll trust you, and they'll sit and say, okay, this provider, this clinician referred me this person for a reason, and I know that they're invested in us and our growth. So I promote always being as much as a part of the community that you're in. And even if you're going into, just like, if you're a resident or if you're a trainee, you are still part of that community, even if it's transient. So I don't see it as I'm only here for a certain period of time, I don't need to do these things. Doing these practices are gonna make you into a person who actually cares, in the sense of, like, cares about the growth of your community and where you're at, and overall society.
Wow. We are at our time. There's so much more that I know that you had to offer. So many other questions that could be asked and answered. But in the interest of time, I just want to close out, just starting off by saying thank you to each of you. Thank you for answering the call to participate, for sharing so candidly, so passionately, so transparently around the diverse and culturally inclusive care. And I hope the attendees, I hope that you are going away with rich thoughts and resources about how you can navigate this space, whether you be a new physician, a fellow, a physician in transition, that you're walking away with a lot of resources and perspective to take with you in navigating culturally inclusive care. I know that as a professional in diversity, equity, inclusion, I'm walking away on fire with information that you all have shared. So I just want to thank everyone for what you've shared today. And if you have, as we have like basically 2 or 3 minutes, I think, I'm going to close it out with having you, if there's something that I haven't asked you, so this will be unique for each of you, that I have not asked you, that you want to share around culturally inclusive care. And I'm going to start off with you, Dr. Ovalle. I'll give each of you a minute, and that's how we'll close out. So, Dr. Ovalle, you first.
I feel like I threw my last minute in there. I think it's important for any for healthcare providers in general to collaborate with the community, and that starts off with if you don't have relationships established, go out there and make the establishments. Build the relationships with the cultural centers, religious institutions, advocacy groups, including LGBTQ plus centers, ethnic community groups, faith-based organizations, etc. Host health fairs, workshops, outreach programs, partner up with language providers, and just overall use the cultural liaisons or navigators that are familiar with the norms, just so that you can learn how to tailor health and what overall is health promotion for your specific communities. That's how you do it. Is by going out there, improving communication and improving trust, making sure that you have, I'm sorry if I'm going over time, and just making sure you have
perfect, yeah.
Just your shared resources and referrals should be language congruent.
Okay. Dr. Doubeni, your 1 minute.
No, I wouldn't need a minute. So culture is undoubtedly important because it is how people express their deepest needs, desires, beliefs, and customs, but also how people express their healthcare needs and unmet needs. And truly it's important for us as clinicians to go into that encounter with humility and be open to understanding the culture of the person in front of you. Be that person white, from a different country, a different race, ethnicity, gender, or sex. And by doing so, we enrich both ourselves and provide a better care for people. And by the way, it also helps us do better research. Couldn't escape that, I'm sorry.
And Dr. Jones, bring us home.
And I couldn't echo what Dr. Doubeni and Dr. Ovalle have said previously is, culture is so important in what we do. And I think starting out, you need to walk into that room, leaving your ego at the door and forming a partnership with that patient, realizing that you may not completely understand their culture, and it's okay to ask about it and to learn about it. And in any portion of care, and as you progress through your practice, collaboration, reaching out to other physicians, working as teams, reaching out to community organizations. When I first started out in my community, it was reaching out to the rabbis and telling them that I understood, what they needed and I was there for them. And that was a huge builder for my practice. But again, connecting with people, and most important, realizing that you're there for your patient to provide the best possible care that you can.
Thank you, everyone. Have a wonderful day.
Thank you.
Thank you.